Thank you for the kind introduction. Good afternoon. My name is Eun-Mi Kang from Severance Cardiovascular Hospital. Today, I want to talk about the heart failure patient in surgical ICU. Let me start with why this matters. Heart failure is no longer just a disease of the elderly. In the United States alone, 7.7 million patients today, projected to hit 11.4 million by 2050. Globally, over 55 million people affected. This is driven by two things, aging populations and the fact that we are getting better at keeping patients alive from heart attacks or valve disease and other cardiac disease. More of them are surviving with compromising heart and eventually coming to us for surgery. Let me show you what that means clinically. Twice cohort, nearly 300,000 surgical patients, nearly heart failure was present in 3.6% of elective cases and 6.6% in emergency cases. 30-day mortality was 3.2% in elective cases and 13.7% in emergency cases. At 1 year, emergency surgical heart failure patient has nearly 40% mortality. Even after adjusting for comorbidities, heart failure independently increases your 30-day mortality risk by 1.8-fold in elective surgery. So heart failure is an independent mortality driver in surgical patients. And it's not just a patient who come in with heart failure. From a multinational cohort of over 9,000 patients, post-operative acute heart failure developed in 2.5 patients, and in patients with pre-existing heart failure, the number jumped to 10%. Let me introduce a case. 67-year-old male, post-op day 1 after elective abdominal surgery. Known heart failure with reduced ejection fraction and LVEF is 40%. He is hypotensive and oliguric. Heart rate is 110 and blood pressure 85/55. Creatinine jumped to baseline 1.1 to 1.8, lactate to 2.8, urine output only 15 milliliter per hour over the last 6 hours. Echo shows EF 28%, E over E prime 16, and mild RV dysfunction. Now here the challenge. Your instinct says give fluid, but he's got elevated filling pressures, so fluid risk permanent edema. Vasopressors would increase afterload and worsen LV function. Inotropes might help, but which one and what dose? We'll come back to this case and solve this together. First section today, first, why heart failure behaves differently from other causes of shock, and second, how we assess the patient at the bedside. And third, how we treat matching the drug to the mechanism. And last, we wrap up. Heart failure is not one disease. It's a syndrome with distinct phenotypes, and each one reacts differently to the same intervention. Heart failure is a pump failure. The ventricle can't squeeze. EF below 40%. These patients can't generate stroke volume. And HAPAPEP is a filling problem. The pump contracts fine, but the ventricle is stiff. It doesn't relax. Right heart failure is different. Sensitive to preload and sensitive to RV afterload. Now layer the surgical stress on top of this. In a normal heart, these are manageable inserts, but in a heart failure patient, they are catastrophic amplifiers. The same intervention can produce opposite response across heart failure phenotype and surgical stress, amplifies that mismatch. To guide the treatment, we need a framework. The Stevenson-Noria classification gives us this. Two axes, perfusion, warm versus cold, congestion, wet versus dry. They create four profiles. Profile A, good perfusion, no congestion, so optimize air meds and monitoring. Profile B, good perfusion but congested. They need diuresis. And profile L, hypoperfused but not congested. These patients may need cautious fluid and sometimes inotropic support. Profile C, the worst combination, hypoperfused and congested. The instinct here is to give fluid, but the priority is warm up first, improve the perfusion with an inotrop, and then diurese. Understanding where your patient is on this matrix tells you what treatment they need. There is three key biomarkers. BMP and anti-BMP reflect word stress and congestion. Use trend, not single values. Lactate is your tissue hypoperfusion marker. Below 2 is normal, and above 2, you have a problem. And above 5, survival is compromised. In the post-op setting, myocardial injury after non-cardiac surgery, elevated or increasing high sensitivity troponin T that warrants ECG and serial monitoring. Now let's talk bedside assessment. I will start with perfusion and flow. There are three tools. LVOT-VTI, this is a stroke volume surrogate. Normal range is 18 to 22 centimeter. Below 18, cardiac output is compromised. The passive leg raise response is key. LVOT-VTI rises 10 to 15% or more with PLR, the patient is preload sensitive. SCVO2, central venous oxygen saturation. Below 70% signals inadequate oxygen delivery to tissues. Use it together with lactate for a stronger signal. PPV and SVV greater than 13% indicate fluid responsiveness, but only in mechanically ventilated patients in sinus rhythm. In spontaneously breathing patients, use PLR plus LVOT-VTI instead. On the congestion side, for tools, CBP above 12 millimeter mercury, consistent with elevated right atrial pressure, but it's a poor predictor of fluid responsiveness. Use it for context, not for decision. And long ultrasound, bilateral B lines in 3 or more zones, it means pulmonary congestion. It's rapid and repeatable and directly responsive to therapy. Then IVC is inferior vena cava greater than 2.1 centimeters with less than 50% collapse indicates elevated RAP. But it's unreliable in ventilated patients, so in those cases, you use VEXUS, venous access ultrasound. It integrates hepatic vein and portal vein, renal vein Doppler. Grade 2 to 3 means venous congestion. It's superior to CBP or IVC alone for detecting multi-organ venous hypertension. Here is a 4-step bedside approach. Step 1, is there hypoperfusion? Confirm the problem exists. Lactate above 2 millimeter per liter, SCVO2 below 70%, clinical signs like mottling, oliguria, altered mental status. Step 2, what is the cardiac output? Quantify it. LVOT-VTI below 18 centimeter, that is reduced stroke volume. Cardiac index below 2.5 means low output. This is your quantitative anchor. Then step 3, why is cardiac output low? This is the differential. Is it preload? Then check IVH collapsibility, PRR response, PPV, SVV. Is it pump failure? Check EF, E over E prime, RV function. Is it afterload? Then check vasodilation or obstruction. Step 4, is it fluid safe to give? Use passive leg raise with LVOT VTI, and if VTI increases more than 10 to 15%, they are preload responsive. And then check lung ultrasound for B lines and VEXAS for venous congestion. B lines are already present or VEXAS shows grade 2 to 3, do not give the fluid. Then step 3 lead directly to treatment. First, the volume depletion, LVT, VTI low, PRR responsive, lungs clear, IVC collapsed. In this patient, give a fluid, cautious bolus, and reassess immediately. And pump failure, LVT, VTI low, PRR non-responsive, B-line present. This patient needs an inotroph, avoid volume loading. Fluid overload, LVT, VT normal or high, output is maintained, but lungs are wet and VEXAS is elevated. This patient needs diuretics. The mechanism should guide the treatment. Now let me address fluid management because the evidence here is humbling. Too much fluid associated with harm. The large retrospective cohort over 131,000 acute decompensated heart failure admissions found that giving IV fluid alongside diuretics was associated with higher rates of ICU admission, intubation, RRT, and in-hospital deaths. An observation study cohort shows us that the severe heart failure and cardiac shock patients show that fluid overload above 5% body weight doubled the 30-day mortality. But restriction above 5 restriction is not clearly better either. The Fresh Up trial was the largest RCT in chronic heart failure patient showed that fluid restriction added no benefit compared to liver intake. It simply made the patient thirstier and more uncomfortable. No RCT has directly studied fluid management in post-operative heart failure patient. We combine the best available evidence with the bedside physiology. When we need to decongest in heart failure patient, we usually use IV diuretics. The furosemide was used usually, and the dose is the usual dose, the chronic usual dose to 1 to 2.5 times. High dose shows better net diuretics in those trial without sustained renal harm. For high dose requirement, provide more consistent plasma level. So if we need high dose of furosemide, we use the infusion. If a response is inadequate after optimization, add acetazolamide 500 milligram IV daily. The Edinburgh trial showed this improved successful decongestion at day 3. And critically, do not stop diuretics just because creatinine rises. Venous congestion itself causes AKI by raising renal venous pressure and reducing perfusion pressure. Congestion can kill kidneys. A transient creatinine rise during active decongestion is acceptable. For vasoactive support, match the agent to the dominant abnormality. Vasodilation predominant. Then start norepinephrine. It is a preferred vasopressor in shock. At high doses, watch for worsening LV afterload, low cardiac output. If the patient are applied the norepinephrine, but the patients show low cardiac output, then add dobutamine. Then low cardiac output, dobutamine first. The beta-1 inotropy, beta-2 vasodilation. Short half-life makes it titrable. Then, but watch for arrhythmia and potential worsening of hypertension at higher doses. If the patient have RV dysfunction and high PVR, Milinon has the advantage of a permanent vasodilation, but its long half-life is 2.3 hours, so this is not titratable. And renal accumulation in AKI is also a concern in the patient with heart failure. As we all know, no inotrope has a proper mortality benefit, so we have to use the lowest dose for the shortest duration necessary and reassess hemodynamics after every change. Then post-operative atrial fibrillation deserves special attention in heart failure patients. Elevated filling pressures cause atrial stretch. So that is the structural substrate. There's surgery at the triggers. It matters more in heart failure because loss of atrial kick drops the cardiac output 15 to 20%. In a patient whose cardiac output is already compromised, that is potentially catastrophic. Rapid ventricular rate then impairs diastolic filling, and you can precipitate acute pulmonary edema. Management depends on hemodynamic status. Hemodynamically unstable patients require immediate cardioversion, 200 joules biphasic. Hemodynamically stable patients need a different approach. Treat the underlying cause first, then fix that. Then for rate control, amiodarone is preferred in HFrEF and acute compensated heart failure. It provides both rate and rhythm control with the least hemodynamic compromise. And beta blockers only if hemodynamically stable and never start them in acute compensated heart failure or cardiogenic shock. Diltiazem and verapamil are contraindicated in HFrEF due to the negative inotropy. For anticoagulation, if the AFib has been present for 48 hours or more, anticoagulation strongly balanced against the surgical bleeding risk. And sometimes, despite everything we do, the patient is deteriorating. That's when we need to know when to escalate. The Sky Shock staging system gives you a common language. Sky stage C is classic cardiogenic shock, hypoperfusion requiring intervention. D is deteriorating despite initial support. E is cardiovascular collapse. And in this, lactate is your guide. If lactate is not clearing toward below 2 millimoles per liter within 6 to 12 hours of presentation, then you will have to restage the patient and consider escalation. Let's come back to our patient. Step 1 is their hypoperfusion. He had hypoperfusion because lactate is elevated and oliguria and hypertensive. The cardiac output is low, and he had low EF, so he had heart failure, pump failure. But he has diffuse bilateral lines and venous congestion, so he have not the fluid. So the diagnosis is cardiogenic shock, Wegener cord, SCARD stage C. The treatment is minimize maintain fluid and IV diuresis plus dobutamine for inotropy. And we have to reevaluate in this patient in 2 to 3 hours with the LVOT VTI, P lines, urine output, and lactate. if there is no improvement, we have to uptitrate the treatment and consider the MCS. So these are take-home messages. The first is not all hypertension is fluid responsive. We have to cautious fluid bolus and use the small boluses. And second, congestion matters as much as perfusion. So venous congestion can cause renal injury and organ dysfunction, so we have to use the fluid cautiously. And third, physiology drives the decision. So we have to use the tools that we can use because there are very many mixed physiology. So we have to think about the physiology. Thank you for your attention.